Here, Uday Chandra from SNS College of Allied Health Science from the Department of BSc Cardiopulmonary Perfusion Care and Technology. Yes, now let's start with the case study based question, Tetralogy of Fallot. Tetralogy of Fallot is a heart congenital disease. Now let's move on to the patient presentation. A patient profile is a 9-month-old male infant with worsening cyanosis episodes. The chief complaints are bluish tint to lips, tongue and nail bleeds, especially during crying or feeding. Recent episodes are severe cyanosis with rapid breathing and limbness lasting 30 seconds after prolonged crying. The mother took him or her to the hospital, and the report shows weight gain, fatigue during feeding, and characteristic squatting posture when breathless. Clinical findings. Now the clinical findings we can find through the vital signs like heart rate 145 bpm, tachycardia, respiratory rate that is 40 breaths per minute, oxygen saturation is 84%. The normal saturation is 95%. Now the patient has 84%, less than that of 95. Physical examination. Small for age, appears anxious, central cyanosis on lips and tongue, clubbing of fingertips and toes. Cardiovascular assessment chart. Loud harsh systolic ejection murmur at upper left sternobordal. Second heart sound S2 or noture. The episode is a hypercyanotic spell, medical emergency, squatting increases systemic vascular resistance, forcing more blood to the lungs. Now the diagnostic workup are, first one is chest x-ray. The patient has to be overcome to the chest x-ray, electrocardiogram and echocardiogram. Chest x-ray refers the boot-shaped heart with the right ventricular hypertrophy, concave pulmonary artery segment and decreased pulmonary vascular markings. Electrocardiogram, right ventricular hypertrophy and right axis deviation indicating the right ventricular working against obstruction. Echocardiogram refers distinctive diagnostic test which confirms all 4 anatomical defects of Tetralogy of Fallot. The 4 defects of Tetralogy of Fallot are: the first defect is ventricular septal defect, large hole between right and left ventricles allowing blood mixing. In this ventricular septal defect, the holes between the right and left ventricles allow some more blood through which it is mixing. Second is pulmonary stenosis. Stenosis means here the narrowing. Pulmonary artery will be narrowed. Narrowing of pulmonary valve and outflow tract which affects the chambers of the heart. Primary defects determine cyanosis of severity. Right ventricular hypertrophy. Here hypertrophy refers, hyper means increased, trophy means increase in the level of numbers, size, etc. Thickened right ventricular muscle valve from pumping against obstruction. Overriding aorta. Aorta positioned over VSD, receiving the blood from both the ventricles. Managing TET spells. The immediate interventions to stabilize the infants during hypercyanotic episodes are positioning, oxygen and meditation. Positioning. Place infant in key chest position, mimicking squatting posture. Oxygen. Administer supplemental oxygen to improve the saturation counts, like the patient has 85% rather than that of more than normal range is 95% of saturation in oxygen content. Medication. IV morphine to calm infant and a beta blocker to relax outflow tract. Meditation here refers to the medicine or a capsule method. Stage 1. Palliative shunt. Ballock-Turzing Thomas BTT shunt. The procedure of this stage 1 is small Grotex tube surgically placed connecting subclavian artery branch to the pulmonary artery. Where the subclavian artery process, it starts from the shoulders of the hands, right and upper limbs. Purpose: bypass pulmonary obstruction, providing reliable blood flow to lungs and increasing oxygen saturation. Outcome: post-operative oxygen saturation improved to 92%. The patient should be as 85% of saturation. Now the patient has 92% saturations. Breastfeeding improved with no further TET spills. Post surgery, the outcome is 84%, and the pre-surgery, the outcome is 84%, and the post-surgery, the outcome is 92%. Stage 2, complete repair. Open heart surgery performed at approximately 1 year of age to normalize blood flow. VSD closure. Ventricular septal defect closed with surgical patch. Cyanosis relief. Excess muscle removed and outflow tract widened, sometimes with a patch. Shunt removal. BTT shunt removed as no longer needed. Surgical success. Oxygen saturation normalized to 98 to 90%. 90 to 90% on room air. Cyanosis and clubbing resolved over time. Long-term outcomes. Excellent prognosis, expected to live active and relatively normal life following complete repair. Lifelong monitoring, regular cardiology follow-up to monitor for arrhythmias or pulmonary regurgitation. Future interventions, potential needed for additional procedures if complications arise. Key takeaways: early recognition. First one is the identify the cyanosis test. Spells, squatting behavior is crucial for timely diagnosis. Surgical approach as are palliative shunt followed by complete repair allows infant to grow stronger before definitive surgery. Excellent long-term outcomes. When with the proper surgical interventions and follow-up, children with a TOF can lead to active, healthy lives. Thank you.